adult foot and ankle examination, and Dr. Samarjit Patnaik will talk on pediatric foot and ankle examination. So Maninder, over to you.
Right, can you hear me?
Yeah, you are audible. Please make it
Okay.
in yes, and it's we can see
Great.
your screen.
Excellent. So first of all, I like to really thank West Bengal Orthopedic Association, Dr. Chinmay, Dr. Rajeev for kindly inviting me for this talk, and hopefully I'll like to finish the talk in time. You've given me 15 minutes, so if I go a few minutes over, please excuse me. I hope that's okay. So the talk is foot and ankle examination, and this basically I've tailored more for PG level students. So basically an introduction to how to go about examining a foot and ankle patient. And I've tried to make it as interactive and with videos as much as possible. I was given a short notice, 2 days. So I've just had my PG students who, with their help, I've made some videos for the examination. So history, first of all, we have to start really what's the problem. We listen to the patient, what he's saying. And the main problem usually patient comes with is pain. If patient has deformity and if it's pain free, usually the patient does not mind that much. But pain is the main problem which the patient comes with, and the pain, because the foot is so diverse in the amount of bones, the ligaments, and the structures that can be the source of the pain. We have to really examine it really carefully to find out what is the cause of the pain. Obviously, there can be reduced function, there can be instability of the ankle or the foot, and there can be cosmetic problems such as hallux valgus, which can be sometimes the source of quite patient discomfort. So, and footwear difficulties. If patients are unable to wear closed-toe shoes, then sometimes that's a problem, and that requires treatment at that point. So first, this is the only 2 slides which have things written on them. The rest of the slides are all sort of more of photographs. So the basic idea before we start touching the patient is to examine the patient and localize the problem area where you're going to actually examine the patient in detail. So you need to localize even in the foot, whether it's the hind foot, the midfoot, or the forefoot. That is the main problem. Or there's something like, maybe a muscle tightness, like gastroc tightness, which is the cause of the problem. So you start with the patient standing. As the patient comes to you, you start with the gait, and then you do a tiptoe standing. You look at the shape of the foot and tiptoe standing, which will just the single stance and the double stance tiptoe standing, and then balance and walk on heels and lateral border of the foot. So that's what we start off with. So this is the shape of the foot that we can usually make out. Sort of the shape of the foot is sort of if you see the first. See that the heel is actually going into valgus both sides. You can see the arch on the medial side is dropping, and you can see the too many toes sign on the either side. So this is a classical tibialis posterior dysfunction foot, and you can see the heel has gone into valgus. Now we have to assess what's happening really. So look at another one. So if you see this is the normal looking foot with the heels in slight valgus. Over here, the heel is completely straight or maybe slightly going into varus. And this is a very subtle sort of cavus or heel varus foot, which we have to really identify with clinical examination. And that's the core of the clinical examination, what we have to do. This is a more, more subtle, but this is more evident varus in this foot. So if you see this heel going into varus, this is looking reasonably okay. And then more, if you see it on the side, you can see that the arch on this side is much more than the other side. So this one is, and the heel is also visible on this side. You can't see the heel on this side on the right, but you can see the heel on the side. So you need to really compare both sides and see that you have, assess the patient clinically. So you've now got an idea that it's the heel which is the problem here. So we start off with the gait. Okay, so there can be, we already know that there are lots of different types of gait that are there. An antalgic gait, the short leg, Trendelenburg, scissors gait, spastic drop foot gait, a higher stepping gait, again with a drop foot, or a shuffling gait, which is more from the hip But in foot problems, usually you will get what is called an adaptive gait. Okay, so the problem, the foot tries to tilt either medially or laterally. So you really have to look at the foot and the gait, and look at the heel position, and look at the position of the arch, and look at the way the heel is going up and down while the patient is moving. So that's the key. You really need to see what all is happening while the patient is moving, and basically focus on the foot. Okay. Sorry. Okay, sorry. I think just something just happened there. Don't know what happened. Just a minute. Can you just see a white screen?
Yes.
Is that it? Yeah,
White.
okay. Just a minute. Seems to have seized up a bit. Okay, just a minute. I'm just going to stop sharing for a minute, okay?
Yes,
and I'll come back.
Sure, sure.
Sorry about this. Just loading it up again. Okay. Just going to start sharing. Okay, can you see that now?
Yeah, yeah.
Okay, so I'm just going to scroll forward. This we've already seen. So this is the next, so this is the single heel raise. Okay, so what we do is we basically get one of the foot up, and we need to see two things over here. One is that how many times the patient can actually go up and down on the single foot. And if you look at it carefully, you see the heel is going into varus as soon as you go there. It's going into varus. From valgus at heel strike is going into varus. And that's the important key. Really, what does that tell us about the whole picture? So if the heel is going into varus when the patient is standing and the arch is forming, if you see the arch is forming very well, that tells us two things. One, that the subtalar joint is flexible. It is moving, it is flexible. The other thing is that the tibialis posterior muscle is working. So as soon as your patient is able to do this, you know that these two things are normal, okay? And the other thing is if the patient is able to do it more than 10 to 15 times on the single heel raise, that tells us that there is, even the stage 1 tibialis posterior tendinitis is not there. So tibialis posterior, but if you get early stage tenosynovitis of the tibialis posterior, like in middle-aged females, then you will get reduced number. They still be able to do it, but they won't be able to do it as much times as on the other normal side. So that's one of the early signs in a stage 1 tibialis posterior tendinitis, which we have to look out for, is the number of heel raises with a single heel raise, which the patient can do. Now let's look at this picture. If you see on the top, both the heel are in valgus. You can see 2 minute toes, and you can see the medial arches drop. As soon as the patient goes up on the toes, the heel stays in valgus. That's right. So that basically tells us either the heel is fixed in valgus or the tibialis posterior muscle is dysfunctional. Either of those things have to be there for this heel not to go into varus. And it's bilateral, the same condition. Look at this now. So there is a flat foot here. You can see the medial arch is completely touching the floor. But as soon as the patient goes up, the heel goes into varus, the arch forms here. So that tells us this is a flexible flat foot. A flexible flat foot, and majority of times these don't really require any specific treatment, and not even insoles or anything. They really don't, unless they're symptomatic. We don't really need to treat these because these are functionally and anatomically normal patients. Now continuing the standing examination, we look at calf wasting, knee deformity, and leg-limb discrepancy. If you see the left knee here, the left knee is in varus. That looks like some trauma has happened. That the calf, there's some injury to the calf there. But if you see the foot, look at the right foot. It's completely normal. Look at the left foot. It's gone into a flat foot sort of picture with the heel going into valgus. And why has that happened? Because the body has to compensate for the varus in the knee. So if you see ladies or gentlemen old who have got severe varus in the knee, you'll find that the foot has usually gone into valgus, and that's to compensate for the varus because the foot needs to be plantigrade. And that's why lots of these knee OA patients get impingement pain on the lateral side of the ankle because the heel is going into valgus. And that's something which you have to really think of doing. And it's the opposite for valgus patients. So there, sometimes the heel tends to go into varus to compensate, but it's more evident in the varus knee patients. So, and leg length discrepancy obviously will alter the biomechanics of the foot, and we have to really look out for that to complete our examination. So further standing examination, you have to make the patient tiptoe. We've done so basically standing on heels. It tells us the functions of the extensors and the the Achilles tendon. A ski stance will tell us whether you can actually dorsiflex how much dorsiflexion of the ankle is possible. So if you do this, ask the patient to do this, he's able to do that, you at least know that at least 10 to 20 degrees of dorsiflexion, as long as the foot stays on the ground, does not lift up while doing this, you can be sure that at least 10 to 20 degrees of dorsiflexion of the ankle is possible. So all these, the inverters and the everters test. So if you walk on the heel, on the lateral border, on the medial border, that tells us about the inversion and eversion power, as well as the flexibility of the foot to actually manage this sort of position. So just by doing this we've not even touched the patient, and we already know so much about the muscle function, about joint flexibility, the joint position, and the range of movement that is possible in these joints. So we've already got a very good idea before even starting to touch the patient. And once we've got this idea, now we have to confirm the diagnosis with further examination. And so I usually start off on the medial side and going from top to bottom, and you basically localize the joint. And first, the anteromedial gutter is the easiest to localize in the ankle joint. So once you localize the anteromedial, exactly the same level as the anterolateral gutter. So you've got the ankle joint now, and you can palpate the center of the ankle now to look at for any tenderness or any impingement there. And that's what you have to look for. So basically palpating all the bony points. And then you have to palpate the tip of the medial malleus to look for any tenderness, and the tibialis posterior tendon at the back of the medial malleus, look for any tenderness over there. So basically the medial structures are mainly these. And then once you palpate the back of the Achilles tendon, look for any Haglund's deformity, any tenderness in the heel. So once you've done that, I move on to the medial side, and you apply tenderness, look for plantar fasciitis sort of pain, plantar fascia, which is more of the medial plantar fascial pain, or you can have pain over the navicular, the medial pole of the navicular. And this is pain, central pain over the insertion to the plantar fascia. So you have to look for all these areas, and then you go on to the lateral side. So this is your other foot, and we're on the lateral side now. So again, lateral side, you want to test for the anterolateral gutter tenderness, where the ATFL ligament is. You have to test for tenderness over the anterolateral gutter, and that's the most common site of pain in the ankle. Now, if you see, the anterolateral gutter is there, exactly there, and this is the peroneus tendon, the tip of the lateral malleus, and the peronei coming here. Okay, and so again, peronei palpating the whole thing, and look for any tendonitis, any swelling, anything else going on there, to the insertion to the peroneus. So, and this one now, if you feel, is basically we've gone to the anteromedial gutter now, okay, and basically testing for any tenderness over that in that area. So, and now we've gone to the talonavicular joint. So it's just about half a centimeter down. This is the intercuneiform joint and the TMT joint. So once you go to the TMT, then you basically move across, feeling the TMT. So this is basically a routine examination of all foot patients that we tend to do, to look for any points of tenderness and any points of inflammation, so that we can isolate the exact source of the pain. So we have to really palpate those joints to know what we are doing. If we don't palpate them, it's basically not really a complete examination. Now the range of movement. So if you have to look for the ankle range of movement, you have to keep the heel neutral. So one hand has to be keeping the heel neutral, especially for these valgus or the flat foot patient where the heel has gone into valgus. And then basically once you've done that, and the other foot tends to move it in ankle dorsiflexion plantar flexion. Now this is testing the subtalar movement. So you hold the talus with 2 fingers, and then you test with the other hand. You can do this. So there's other ways of holding the talus in position, which you can dorsiflex the foot, and that will also hold it. And this is another way of holding the talus and the calcaneum in one way. And now we were rotating the foot. So this is midfoot rotations mainly over the Chopard joints, the talonavicular and the calcaneocubar joints. And now you have to test for the MTP joint movement. So if you see, it's about 70 to 80 degrees of dorsiflexion is possible and 30 degrees of plantar flexion is possible at the first MTP joint. If there's anything less than this, this is not normal. And you have to know the plane of the metatarsal, as we showed with the finger, is very, very specific and is plantarwards. Now the second MTP joint is really important for transfer metatarsalgia. So you have to keep 2 fingers, one on dorsal, one on plantar aspect of MTP joint, and move it down. And if there's any synovitis, any problem with transfer metatarsalgia because of hallux valgus or hallux rigidus, you'll get specific pinpoint pain. The patient will cry out in pain when you do this. Now, this is the testing for instability of the first TMT joint. So if you hold the first and the rest with the 4 separate metatarsals, and if you look for any instability of the metatarsal, the dorsal subluxation of the first TMT joint, you'll be able to feel for excessive subluxation. So that's the majority of the range of movement done. Now we have to come to muscle power. So you basically plantar flexion. Okay, now we are testing for basically instability. Okay, so you turn the foot inwards about 20-30 degrees, internal rotation. You get the heel off the floor, balance it with 1 foot. So there's some space between the calf, and then you push it down. So this is one way of doing the anterior draw test. Okay, this is not a conventional way, but this a lot of foot and ankle surgeons follow this. And you have to look for basically dimpling of the skin in that area in the anterolateral gutter. If you get dimpling in that skin, so this resident did not have any instability, unfortunately, but that's what you look for, is dimpling of that skin in that area in the anterolateral gutter while you do this. Now there are 3 or 4 ways of doing the anterior draw test. The foot has to be kept in 20 to 30 degrees of plantar flexion for this to be done properly, and you have to have some stability of one end and we move the other side. Okay, so in here we are stabilizing the foot, but we are moving it with and we're pushing the tibia. So pushing the tibia back and the talus is coming forward. The other way of doing it is stabilizing the tibia and then moving the talus forward. Okay, doing this. And again, what you're looking for is any dimpling of the skin over here. Okay, so you can switch hands, and there's other ways of doing it by holding the tibia with just this single hand anterior draw test as well, which requires a bit of practice, which is basically done like this. So if you hold it like this, the other top finger is holding the tibia and the bottom fingers are pushing the talus forward. Okay, and again, what you're looking for, you will see this dimpling of the skin over here, and you're pulling the foot with the other hand. Now this is another way of doing the anterior draw, fixing the foot again and pushing this back. So lots of these tests are possible. Whatever you're comfortable with, you do that, and basically is to isolate how much instability there is in the foot. Now we come to muscle power, strength. Okay, so how to isolate the muscle power strength? So this is basically eversion of the foot and plantar flexion. So what you see is this is the peroneus brevis, which is responsible for this function. If you have to test the peroneus longus, it depresses the first metatarsal. Okay, so that's the function of the peroneus longus. So this is what we're testing the peroneus longus. While we're checking for contraction with the other hand, we're asking the patient to push down the first metatarsal over the thumb, which so it's basically resistance. See how much power there is in the peroneus longus. Now this is the medial side, and we're testing the tibialis posterior muscle. So there's 2 ways of doing it. Either you deform the foot in the position of the tibialis posterior action, and then you try to bring it back to neutral, or from the neutral position, you ask the patient to go from neutral position to the varus position. So either way you can test for all the muscles is either start from the position of neutral and go towards position of deformity, or you start from the position of deformity and try to go towards neutral. Both of these are absolutely acceptable methods of testing the muscle power. So silver skewer test, we know for gastroc tightness, which is really one of the first tests you should do while the patient is lying down, is test for gastroc tightness. So how do you test that? Because the gastroc goes above the knee, when you flex the knee, there tends to be more ankle dorsiflexion than if you were to straighten out the knee. And this is a sign of gastroc tightness. If you see this, there's a neutral ankle with the knee flexed, but with the knee straight, there is about 20 degrees of the plantar flexion. So there's a modified way of doing this is basically to find out subtle gastro tightness. Is basically you start with the position full dorsiflexion first, and you straighten out the knee. So if you see, as soon as the last 10 degrees of knee extension is done, the ankle tends to go into a bit of plantar flexion. This is not normal, okay? So even 10 degrees or 20 degrees pushing down, and you can actually feel the plantar flexion pushing on your this hand here, okay? And even this is not normal. So there is some gastro tightness in this patient. And now you're basically looking for a Mulder's flick for Morton's neuroma, and you squeeze the foot with one hand, and you feel for something clicking inside this second web space or third web space, fourth web space. And if you feel something popping in and out, and the patient has having pain, then this is called sign of a positive sign of a Morton's neuroma, although it's not a completely diagnostic test as such. This is the one of the other tests for looking for Achilles continuity. So if there's an Achilles tear, you wouldn't get this squeeze test, will be negative. The calf squeeze test will be negative. You can see the plantar flexion is happening whenever you do that if you have Achilles tear. Now coming to the Coleman block test. So basically this is to look for whether there's two things which we look for in cavus feet. This is basically for cavus. We're looking at one thing is whether there's any flexible, whether deformity is correctable, and the deformity is flexible or not. So what you do is basically first metatarsal is dropped down off the block. The heel is on the block, but majority of the heel is on the block. Just the medial aspect of the heel is off. But the first metatarsal is completely allowed to bend down. Now, if you see this here, the patient has got, when they put it on the foot here, you see this varus, first metatarsal is not corrected. But if you go to the next picture here, if you see this, on the ground, the heel is in varus. But as soon as you put it on, allow the first metatarsal to drop down, the heel goes into valgus. So this is a correctable deformity, and this is the forefoot driven. So as soon as you get the first metatarsal down, the heel corrects. That basically tells us the primary deformity is in the forefoot. And what does that mean? Basically, it tells us that the tibialis anterior muscle is weaker, the peroneus longus muscle is stronger, and the peroneus brevis muscle on the outside is also weaker. So we have, it's basically the overactivity of the peroneus longus compared to tibialis anterior, which depresses the first metatarsal. As soon as the first metatarsal goes down, there is no way that the foot can be plantigrade without the heel going into varus. So the heel going into varus is a secondary phenomena. It's not the primary phenomena. Now there can be cavus feet in which the heel varus can be the primary phenomena, such as arthritis of the heel, of the subtalar joint, or any specific deformity of the subtalar joint, or in Charcot-Marie-Tooth disease. Sometimes you're going to have primary heel varus, which can lead to secondary deformity of the forefoot. So we have to really, these tests tell us whether this is a primary cavus, which is forefoot driven, whether it is flexible, or whether it is a hindfoot driven cavus. Now coming to impingement tests. So there can be different types of impingement in the ankle, and these are really phenomena which we need to be aware of, because anterior impingement is the most common problem in the ankle worldwide, and this is the most common diagnosis in the ankle. And anterolateral impingement is because of the injury to the ATFL ligaments, the lateral ligament complex, causing a bit of synovitis inside the joint as the ATFL does not heal properly, and it's more of an intra-articular sort of ligament. So you cause synovitis and pain in that anterolateral gutter. And so as soon as you press the anterolateral gutter, let's move it forward. So if you press the anterolateral gutter there and you dorsiflex the foot, if your pain increases, then basically this is an anterolateral impingement, which is there. Same you can do for anteromedial, and this is the subtalar joint. So you can see the gutter and the subtalar joint are very, very close. So this is anterocentral impingement, and you dorsiflex and see for any pain in this. It can be due to osteophyte, due to arthritis of the ankle, or the anteromedial impingement, which can be either due to deltoid injury or due to a talar OCD, which may be very commonly present in these positions. So just coming on to posterior impingement, usually due to an enlarged os trigonum or due to FHL tendinitis, you'll get posterior impingement. This is more common in athletes. So the pain in the posterior ankle, which aggravates on plantar flexion, is a typical sign of, so if you press down like this over here, on both sides of the posterior part of the ankle, you'll get pain. The patient will tell you specific pain over the posterior aspect, which improves with dorsiflexion, but increases with plantar flexion. So, and coming to the last slide, okay, so I think I've already taken too much time. So forefoot, I'm not going to detail here, but always examine standing. That's the main pearl which I can tell you. The forefoot deformities, there'll be many forefoot deformities, whether they're correctable. We can discuss that further on. But that main thing is to examine the patient standing in these cases. So in summary, you have to examine proximal to distal, starting with the hip, the knee, and then going on to the foot, and examine from all the sides, dorsal, sole, the medial, lateral, plantar. So the sole side, you have to be aware for any corns or calluses which are there. And you have to, once you've seen all this, you have to make a specific diagnosis of exactly which joint is involved, which tendon, which muscle is actually tendinitic, which is together associated tendonitis, official tendonitis, or something. So you have to make a specific diagnosis, and all the examinations geared towards helping us. Because once you've made a diagnosis, then the treatment part is usually simpler. So thank you very much.
Thank you, Maninder, for excellent presentation. Please stop sharing your screen.
Okay.
Yeah. So MAINAK Sabyasachi, is there any question? Welcome, Partho. Our secretary, Dr. Partho Sarkar is joined.
Welcome all. Due to some internet problem, I have not been able to connect at the right time. So welcome, Dr. Maninder.
Thank you very much.
SAMARJIT PATNAIK and Dr. Devashish Senara, sir.
Rajiv da,
Yeah.
there are two questions with me.
Yeah. Yes.
Yeah. Suppose because for PGTs, one of the common case given is a old TA injury, tendo Achilles. So in such cases, especially in an old TA, what are the other muscles they should look for the power and examination? Because in a short case, they need to examine in a short time, very briefly. So old TA, how to assess that thing? If you can give us some
Yes,
enlightenment.
Maninder, please.
Okay. So if you have a chronic TA rupture, what is the so main problem there is you'll find that there will be some excessive dorsiflexion possible. So some of the positive signs are basically a chronic TA rupture is more of excessive dorsiflexion possible because the patient has been moving. So resting stance of the foot will not have that. If you make the patient prone, the resting stance of the foot will be more in dorsiflexion rather than plantar flexion, as in the normal foot will be there. So you can compare with the other side. Now, because the tender Achilles is completely gone, you may still have some residual plantar flexion power possible. Okay, and that plantar flexion power is usually weak. It's not good enough to do a single heel raise test, but it will be good enough to actually do a resisted grade 4 plantar flexion power against your hand. And that's basically because of some of the capsular attachments, as well as the plantaris muscle, the FHL muscle, and the peroneal muscles which are there, which are contributing to the weak plantar flexion that is there. So all the plantar flexors will contribute to that, but they're not good enough to do a single heel raise independently. And that's, I think, one of the differentiating points, really. The gastrosoleus is already gone, so in a complete TA rupture. So that power, we can't really isolate from the other plantar flexion powers as such.
So, one question also the examiners ask commonly, that is how we can assess the plantaris muscle separately. Is there any way we can assess whether it is intact or
so
damaged? Or
sometimes you can feel it, okay, but I don't think there's any actual, reliable way of actually testing whether the plant, because as soon as you make the plantar flexion possible, sometimes you can feel a very strict tight band there, and you can actually feel that quite well. You can feel the plantaris muscle there intact, and that's quite a good way. If you see no tight structure at the back at all, then you can be sure then plantaris muscle is also possibly gone. But if the plantaris muscle is intact, what clinical finding? I don't know how to test the individual muscle power as such, but because plantar flexion power will be still be sort of contributed to by the other plantar flexors like peroneal and itibialis posterior. But you can see a tight band. You can feel a tight band at the back of the arm.
Okay, Rajiv.
Yeah. Sabyasachi, any question there? MAINAK?
Yes, there is one question, Dr. Maninder. What are the movements of the ankle joint? Asked by one PGT.
Okay, so ankle joint has a very specific biomechanics. Okay, so it's not really a hinge sort of joint. It's got lots of different movements. Okay, it's not just plantar flexion and dorsiflexion. So what happens is when the ankle plantar flexes, it also goes into a bit of the talus, because the talus is wider at the back. Okay, in the body of the talus is wider at the back, or wider in the front, and it is narrow at the back. So what happens in the normal ankle biomechanics, as the foot plantar flexes, the ankle plantar flexes, the talus goes into a bit of inversion or internal rotation. And as soon as it dorsiflexes, it goes into external rotation. And that external rotation is only possible because the fibula has to move out of the way. So as soon as the ankle dorsiflexes, the fibula has also to externally rotate at the same time to allow that talus to come back into position. And the fibula has to move back or translate backwards or posteriorly to actually allow the wide part of the talus to come into the mortise. So these are all these. So as with plantar flexion, there is internal rotation of the talus. With dorsiflexion, there is external rotation of the talus. And that's the complex movement that is there in the ankle, along with the movements of the fibula, which is external rotation and posterior translation.
Okay, sir. So next question is, what is supination and pronation of the foot?
Yes, I think that's an excellent question. Okay, really an excellent question. So it's a combination movement. That's the sort of, so supination, now different people have different definitions for supination and pronation. Okay, so there's, I think what I'll tell you is the most common, what people would tend to agree with, is that supination is a combination of heel varus and forefoot adduction. Okay, so that's the two movements that is there. So the forefoot adduction is basically happening in the show part joint, the talonavicular and the calcaneocuboid joints, and the heel varus is happening at the subtalar joint. And that's the movement, and the pronation is the opposite movement, is of forefoot abduction and heel valgus. So that's the combination movement of pronation and supination, which is both happening at the subtalar joint and the midfoot joints.
Okay, sir. So, Wboa, any questions you have?
Sorry, sir, can't hear you.
Yeah. I think there are no more questions now. So, Wboa, unmute yourself.
Okay.
We can't hear you. We can't hear your voice. Okay. I don't think any more questions are there. So let's start with the next presentation. So after that, we can take other questions also.
Okay.
Sir, you can start your presentation.
Okay. Welcome to the West Bengal Orthopedic Association webinar for the postgraduates, the postgraduate PG course. So my job is to start an examination of the pediatric foot and ankle. So my first slide is the disclosure. I want to thank Dr. Bibhudatta Sahu, my colleague, who does exclusive pediatric orthopedic work. And most of the clinical photographs in this presentation, I borrowed from him for educational purposes. Objective of this presentation is the presentation will give you an overall idea about the different pediatric orthopedic foot and ankle conditions. And most of the time in your exams, it is a spot the diagnosis. And definitely it helps you to get a diagnosis in most of the times, because deformity is what is most evident. And also it helps you to plan the treatment. If you go to classify the pediatric foot and ankle conditions, they are like any other part of the orthopedic examination. They are divided into the congenital, developmental, metabolic, infective, traumatic, tumors, and miscellaneous conditions where there is neuromuscular disorders like myopathies and cerebral palsies. Now here it is important for us to understand that what the mind knows, only that we are prepared to comprehend and see. So coming to the pediatric foot and ankle examination, let's try to approach it slightly differently. Now we have so many D's and some P's. So if you are considering about a deformity and deficiencies, most of the time it is picked up by our inspection. So we have to be very, very thorough in the history taking and the inspection. And most of the time, 50% of our clinical diagnosis comes by a proper history and a proper inspection. When it comes to any dislocated conditions or any discrepancies, any decrease in the joint mobility, paralysis, or any physical issues. So there, along with the inspection, we have to add our skills of palpation and movements and measurements. Now let's go to the most, one of the most commonest ones, that's the equinus deformity. So here is you see the first picture. Now this is a idiopathic tendoachilles tightness. And in the second one, if you see, it is a question with spasticity in a cerebral palsy child. So there's a tight spastic gastrosoleus muscle there. And then the third one, if you see, there is a swelling and which is shiny, and there is some calf abscess, and sometimes the pseudotumors of hemophilia also can present like this, and that leads to an ankle deformity. And for ankle is an equinus. And also in post-polio residual palsies and traumatic conditions, you can have such equinus deformities. And here, if you see, this is a picture of a 4-foot equinus, and here we have to differentiate it from a cavus deformity. So this is again a very important clinical point which you have to learn from deformities. Now coming to the most commonest one, the equinovarus deformities. Now, okay, so this is the most commonest, the congenital talipes equinovarus. Most of you will have it as a short case. So you have to know what are the tight, what are the structures which are contributing to the equinus, what are the tight structures, what are the structures which gives to the hindfoot varus, 4-foot adduction, and the 4-foot equinus of the cavus. So these are various structures which are tight and gives to this. Now coming to this clinical picture, if you see, you can see there is still existing some amount of equinus deformity. And this is a case of a relapsed CTB, where you can see the foot is definitely smaller compared to the other one. So that's again an important aspect of clinical examination in your inspection. When you see a deformity, you have to be very careful in noting the size of the foot also. Now here, there is a picture where in the first picture, it is basically a metatarsus adductus. And whereas here, the entire 4-foot is an adduction. So this is, you have to differentiate. So this is a 4-foot adduction in a congenital talipes equinovarus, whereas this is only a metatarsus adductus. And when it comes to congenital club foot, the underlying abnormalities are in the muscles and in the bones. Now you can have such type of varus and equinus foot in common peroneal nerve palsies because of muscle imbalance. And also in cerebral palsy, you can have equinovarus foots where because of the spasticity. Now let's go to the calcaneal deformity. Now this is calcaneal deformity is one of the most forgiving ones. They are usually not very tight deformities. There is a calcaneovalgus foot, and usually these are supple deformities. There's not much of muscle imbalance, so usually they are passively stretchable and correctable. And when there is some amount of rigidity, the contracture releases are at times required. And there are also various causes for acquired calcaneus deformity, which at times you have to go depending on the amount of deformity, osteotomies and tendon transfers. And at times when it is acquired calcaneus deformity in a slightly older child, and it's very tight, and sometimes we have to go for triple fusions also. Now let's go to the next common deformity, that is the cavus deformity. Now this cavus deformity is usually, if it is mild and there is not much of muscle imbalance, it's again a spotter. When you see, you have to differentiate it from a 4-foot equinus. And usually this can be modified with shoe modifications. And again, when there are deformities are very tight and in older children, you have to go for triple fusions. Otherwise, muscle releases and some muscle, you have to know the exact diagnosis, and accordingly we can go for transfers or release. Now, the other common condition which is seen in your exam setting is a congenital vertical talus. So if you see here the classical rocker bottom foot, which is again here important to plan is your lateral view x-rays, which is a must, and that only after that you can also plan your treatment there. So basically most of these deformities are spotters here, where seeing at the foot you have to plan your deformity. Now here, if you see, we'll go into a planovalgus foot. This is a very common deformity which you see, and this is basically a pes planus condition where because of the accessory navicular you see here, and here in peroneal spastic pes planus also you see there, and sometimes in tarsal coalescence also you can see a flat foot deformity. So again here, most of the time you reassure the parents and they encourage barefoot activity. In younger children this gets modified. Unless they're like in older children, rarely, I mean, you have to plan for your insole arch and all. And in severe flat foot, painful, and you have to at times remove the painful flat foot, you have to tackle to the accessory naviculus. Otherwise, in older children, unacceptable and severe flat foot, times you have to go for osteotomies. So valgus deformity of the ankle. Now here, if you see, this child has got a, there is a valgus at the ankle joint. So this child has got a fibular physeal defect for which there is a deformity of the ankle joint. Now here, if you see an ankle varus, now here it's a case where this child is having a loss of the fifth toe, which suggests an X-ray. There is a fibular hemimelia, and these are the cases where they also present with a valgus at the ankle joint. Now, here is a case of a post-infective case where there is a deformity of the ankle and there is a sequelae of septic arthritis and there is a varus ankle there. Metatarsus adductus and skew foot, these are also common deformities which you see as I show you in this picture. So here, the difference between the clubfoot correction and metatarsus adductus is in clubfoot, you have to have the pivot at the level of the talus, whereas in a metatarsus adductus, you have to do it at the calcaneocuboid joint, and you have to correct. Now, this is a primary metatarsus adductus. So you have to differentiate it from a varus foot and a cavovarus foot. Now, coming to the other deformities like forefoot and toe deformities, here is a case of a primary hallux valgus in a 12-year-old girl. She has nothing apart from hypothyroidism. She has no other condition, but here sometimes it is seen in metabolic bone conditions. Congenital hallux valgus can be seen. And here you see a hallux varus. It's a post-traumatic condition where there is a scar on the medial side leading to a hallux varus condition there. Now here you see there is a second left toe case where there is a length alteration in the length. There is a length discrepancy. So this is a macrodactyly here as you see. And sometimes again, you have to keep a note on these various callosities which develop in a spastic foot. So these callosities because of the flexor spasms, they are seen in CP children. And when it comes to these multiple constriction bands, and sometimes this is leading to auto amputation of the disease, the digits. So these are also conditions which are basically spotters, and you have to identify these conditions just by looking at the cases. And these are cases where you see callosities. It's a CTAV child of the lateral aspect of the foot. Here it's a student sitting, and there is a lateral bursitis over the lateral malleolus. And these are the conditions which are basically given in exams, and you have to spot this diagnosis. Now, tarsal coalitions, at times it can lead to also a flat foot and a planovalgus foot. And here, if you do the movement, if you compare to the normal side in tarsal coalitions, the movements are restricted at the midfoot level. So basically, when it comes to a deformity, and even in your examination sitting, you have to be, when you are able to provide the diagnosis, you would be asked very commonly the question that how do you decide? So basic, the treatment which is based on the deformity, the decision making is based on two important things. One is the natural history of this deformity. Now, if this deformity tends to resolve spontaneously, then you have to reassure and follow up these cases. Now, if this deformity tends to progress, then you have to suggest for early intervention to correct the deformity. Now, if the deformities, they are remaining static, then the decision to intervene is based on the consequences. What's the natural history? And then what happens if this deformity stays for long? Now, coming to the consequences of this deformity. Now, if this deformity which is there is only cosmetic and there is no other disability, you might not go for any intervention. And sometimes there is a cosmetically, these are unacceptable, but it causes no functional disability. Then you have to weigh the pros and cons of intervention. When the deformities that cause are having disability, then obviously you have to go for intervention. And deformities that potentially lead to deleterious consequences, then you have to again intervene early in these cases. And deformities that can at times may be beneficial, which is a compensatory one. So avoid correcting these type of deformities. So that is how you have to answer once you get a case and you find able to establish a diagnosis. You are seeing the deformity, examine that. And you have to, whenever it comes to asking you, the examiner asks you about planning the treatment, you have to plan accordingly. And that are conditions where there is hyperlaxity. So here you see the reverse of the equinus deformity here. So there is a hyperdorsiflexion of the ankle, and there is generalized hyperlaxity in this girl. And infections, always you have to look for a scar somewhere. Whenever you see a foot or any part of the body any scar, then you have to have the high index of suspicion for an infection. And again, swelling is very, very important as the deformity you have examined in your inspection. So swelling, you have to again note where exactly it is the site of the swelling. And usually it is because of any traumatic condition, inflammatory condition, infections, or any tumors. Now here, when it comes to a child and a history of trauma, the clinical examination is very important in traumatic child when the X-ray looks essentially normal, because here there might be some physeal injuries and or there is some perichondral ring injuries. So hence, you have to be very, very careful in the clinical history and examination where you have to find where exactly the point tenderness, and accordingly we have to treat these children. And the scars, again, it again suggests us about any post-traumatic history or post-infective history or post-surgical history. Now coming to ulcers, when you have such like syndromic babies where there can be multiple joint involvement, and this is a meningomyelocele and there is insensitivity to pain. So these, and sometimes even cerebral palsy children, they can, because of the chronic posturing, can develop ulcers. So you have to keep an eye on that and examine that, and what is the extent of the ulcer and depth of the ulcer. Now, apart from inspection, when it goes to palpation, again, you have to corroborate your findings, find out if there is local warmth suggestive of any infection, any localized tenderness, as in case of children, there might not be anything much evident in an X-rays, or any evidence of infection or any hemangiomas. And here, as you see in this child, there is a foreign body granuloma. So you have to be very careful in your palpatory skills also. And vascular assessment, as in all cases, you have to look for your anterior tibial, the posterior tibial, and the dorsalis pedis sensation. Neurological status evaluation is difficult to assess in children for the foot and ankle conditions, but you can check for the muscle contraction by stimulating different parts of the sole. And coming to the movements examination, they can be reduced, and the common causes for reduction are maybe because of any infection, trauma, and cerebral palsy. And if there is any contractures like amyotrophic, your arthrogryposis multiplex congenital, or spasticity, or any septic sequelae. And as always, the examination of gait is very, very important in any case. So here we have to see if there is any tiptoeing walking, what are the different types of gaits, like crouching gait or jumping gait of cerebral palsy, or the in-toeing gait is also very important in case of pediatric foot and ankle examination. And always you have to examine for the knee joint, the hip joint, examine the spine, and examine the upper extremities also. And last but not the least, whenever you are examining any foot and ankle case, you have to examine for the footwear also. So thank you for your attention, and my sincere gratitude to Dr. Vibhudatta Sahu, who has really helped me to get all the clinical pictures for this presentation. Thank you, sir.
Thank you, sir, for your excellent presentation. Subodha, any questions?
Please stop sharing your screen here.
Yeah.
Subodha, we can't hear your voice.
Hello.
Problem with
Hello.
Yeah, MAINAK, go ahead.
Yes. One question to Dr. Patnaik. CTEV is one of the most common cases that is given to MS or DNB students.
Yeah.
One of the questions that is frequently asked is how you will clinically establish forefoot adduction, separately equinus and separately varus. How to clinically demonstrate these three things on the child: forefoot adduction, varus, and equinus.
So equinus is at the ankle joint, so that you have to test for the tibiotalar joint movement. The other one is the adduction. So adduction and the forefoot varus. Yeah. So adduction again is at the subtalar joint, the adduction and the abduction. Whereas the forefoot is like you have to hold the forefoot adduction. For that you have to turn, and it's at the Lisfranc's joint. So that is by correcting at the level of the tarso-metatarsal joint. The varus is at the subtalar joint, and equinus is at the ankle joint. So that exactly, I don't have a model to demonstrate, but that is basically, I think Dr. Maninder has wonderfully demonstrated how to evaluate in an adult case. So the principles basically remain the same.
Yes, yes. Professor Chinmay sir, you want to add
Chinmay
anything
sir,
else?
your opinion on this?
Yes, nicely described. CTB equinus, passive examination, you cannot take the ankle joint to neutral position. And for the adduction, if you compare with the dividing line is the mid-tarsal joint, that is the talonavicular and calcaneocuboid. So if you draw a line joining these two joints, you can easily identify that the part beyond that line is not matching with the hindfoot. It is deviated medially. That is the adduction. And another is varus. Varus, if you see from back, the heel is rotated medially, so naturally it is the varus. So by these three joint, one is varus heel, other is inability to bring the ankle joint to the neutral position, and the forefoot is deviated medially. So these are confirmatory of the diagnosis of your CTB.
Sir, in most cases, the child is unable to stand because it is a small child. So in that case, do we make the mother hold the child and examine from behind?
Yes, that is the rule, because most of the cases, what is given in the examination, it is non-weight bearing child, less than 10 months or like that. So always comfortably the child should sit in the mother's lap and then he should examine.
Hello, Arnav, can you hear me?
One.
Yes,
Arnav.
Sabyasachi.
Yes, Sobbata, go ahead.
Hello, Arnav, can you hear me?
Yes, Sobbasachita, go ahead.
Yeah, please ask your question.
Okay. So there is a question, how will you differentiate clinically a heel varus and a heel valgus?
That just discussed, I think.
Yeah. Dr. Maninder, you can throw.
So, yes, if we have to see, you can either see by this heel raise test from the back, looking from the back of the heel, whether the heel, when you stand, it should be in slight valgus, about for 10 degrees of valgus or neutral. And as soon as you go to tiptoes, it should go into about 20 degrees of varus. So one thing, we can see it from the passively. The other way is to actually examine the range of movement that is there in the subtalar joint. And there is a significant amount of heel varus and valgus possible in a normal joint. At least 20 to 30 degrees of varus valgus is possible in the subtalar joint. So the main thing, the important thing is to stabilize the talus in the mortise before you move the subtalar joint. And there are 2 or 3 ways of doing that, as we demonstrated. You can either dorsiflex the ankle, that will stabilize the talus, and then you can use the subtalar joint. But I find it more easier and better because dorsiflexing the ankle stabilizes the subtalar joint as well. So the movements are reduced. Sorry, just a minute. So subtalar movements are reduced if if you actually dorsiflex them. So better way to do right plantar flexion and hold the talus with your other hand, and then move the subtalar joint medially and laterally, and then you can assess how much movement there is compared with the other side. I think that will tell you exactly what is happening.
Yes.
Okay, another question is, what is too many toes sign and what is its significance?
Okay, so too many toes. Can I answer that? Sorry. Yeah.
Yes. You may answer.
Yeah.
So basically, too many toes sign is when is basically seen in cases of flat foot. So if you're looking from the back, if you see on the lateral side of the heel, you can see too many toes on one side, and the other side there's not many toes. So it's basically because of forefoot abduction. So as soon as forefoot abduction, you can see many toes on one side and less toes on the other. Then it's basically called as too many toes. Basically, with forefoot abduction, you can see more toes. That's it.
Normally, how many toes we can see from behind?
So one or two, I think. but you compare with the
One
other
up,
side. It depends on what the stance of the patient is when he stands. Some people stand with a bit foot externally rotated, some stand, slightly like that way. So it basically always compare with the other side, but usually 1 or 2 toes is normal, and if you see all 3, 4, then it's more than normal.
It's a fourth and fifth normally we see. Fourth and fifth. Yeah. Normally. So
I
if you can
think
see third or second.
fifth and half of the fourth.
Fourth, yes, that we can see. So another,
there
Sabyasachi,
is
any
a
more
question.
questions?
One question is there in YouTube. How to differentiate forefoot equinus and Wboa?
Samarjit?
How to differentiate between forefoot equinus and Wboa?
I think there is some network issue with Samarjit. Maninder, you can answer this question.
So if I understand correctly, forefoot equinus is dropped first metatarsal.
Yeah.
Is that correct?
Right.
Yeah.
Yes.
So,
Yes, I do think so.
Yes.
So basically what happens in a dropped first metatarsal, it's usually a neurological phenomena because of imbalance of muscle forces. So the question is, how do you differentiate between a dropped first metatarsal and what else?
Wboa.
Oh, Wboa. So it's dropped first metatarsal is part of a cavus foot, a Wboa foot. So it's one of the components of a Wboa foot. So usually if it's a forefoot driven cavus, the drop will be first in the first metatarsal, and because now the foot has to become plantigrade. If you drop your own first metatarsal, you'll actually know what it means. So once the first metatarsal, because it's a tripod, so once the first metatarsal is dropped, the heel has to go into varus to actually become plantigrade, the foot to become plantigrade. Otherwise, you won't be able to make the foot plantigrade. So once the first metatarsal is dropped, the heel varus is secondary to make the foot plantigrade, and that's what happens in a Wboa foot, basically. So varus of the heel is secondary in a forefoot driven cavus. The other ones are hindfoot driven cavus, where the varus of the heel is primary and the drop first metatarsal is secondary.
Okay.
Okay. One question is how to measure the length of the foot. Professor Chinmay, sir, if you want to answer that. How to measure the length of foot?
Length of foot. Length of foot is medial length and lateral length. First, you place one cardboard on the posterior aspect perpendicular to the heel, and then the distance between is the length, and another cardboard to the perpendicular and measure on the lateral side. Two lengths actually, medial and lateral.
Okay. Singora sir, any opinion? Singora sir, please unmute yourself.
Oh, thanks, Rajeev.
Yeah. So any opinion on this, sir? About foot? No. Yeah.
Go on, Rajeev.
Yeah. So, Sabyasachi, any more questions on YouTube or Facebook or WhatsApp? There's one.
No. Another question is there. How to differentiate in-toeing due to femur and tibial pathology separately? How to differentiate in-toeing due to femur and tibial pathology? Professor Chinmay, sir, you want to take up that question, please?
Due to femoral pathology, so along with the toes, the patella also will move medially. But if it is due to tibial pathology, patella will remain in normal position. If the patient examines in supine position, only the toes will move medially.
Okay. So we will examine the patient in standing position or supine position?
Supine position, lying position actually. Better.
Okay. Is there any role of thigh foot angle in these cases? Differentiating in these cases?
That is the severity of the condition. Thigh foot angle actually determines the severity of the condition. But pathology to be differentiated in where is the pathology, so you have to first you go for the test only, test in supine position, examine the patient in supine position. High foot, it is the tibial, actually it is the measurement of the tibial torsion, medial or lateral.
Tibial torsion.
There is one question for Maninder. So for ankle movement, normally, whether we should do it in a supine position or prone position. So some clinical book it is demonstrated in prone position, some clinical book it is demonstrated supine position. What is your say on that?
So I would say whichever way is okay. You can either compare it in supine, or supine is easier to do. So normally we would not do a prone position testing in a normal method. The only thing to really be careful of is that when you have these flat foot patients or hyperlaxity patients, what they tend to do is as we say that the ankle dorsiflex also externally rotates. So as soon as these flexible patients, when they externally rotate, or the ankle dorsiflexion looks much more than normal. So, but it is actually not true dorsiflexion. The only way to counteract that is to actually keep the heel in a neutral position with your hand. And if you do that, then you will get true ankle dorsiflexion and plantar flexion. I don't think it matters whether you keep it in supine or prone position.
Either way is okay.
The other side, yeah. As long as you keep the heel neutral.
Hello, Rajeev, just one more clarification regarding the question on equinus, forefoot equinus and cavovarus, how to differentiate. So important point here is in forefoot equinus, so all the 5 metatarsals, they are dropped, and usually this happens at the metatarsophalangeal joint level, whereas the cavovarus, the cavus happens at the midfoot level and varus is at the hindfoot level. So this is good.
There's one question for Samarjit, that how to differentiate between a tight gastrocnemius and tight soleus? Very commonly asked.
Very commonly asked. Okay. So, yeah, anybody wants to take that?
Maninder?
Yeah. So,
yes, I think sir demonstrated the silvestrial test very nicely.
Maninder, just this question.
Basically, what happens is the soleus tightness will be the same whether the knee is flexed or extended, and the gastroc tightness will change. With the knee flexion, the gastroc will not appear tight, but with the knee extended, the gastroc will appear tight. So if there is change in the ankle dorsiflexion and plantar flexion, when you flex the knee, then it is a gastroc which is involved. Soleus is not involved. But if there is soleus tightness, then it will be the same movements in knee flexion, with the knee flexed or the knee extended. I think that's the main difference. And you can use the silver test to do that, to differentiate between the two.
One question for Dr. Maninder: how to differentiate hindfoot varus due to primary and secondary cause?
Okay. So I think that's a great question. See, primary hindfoot varus, it depends on what stage the problem is. Usually, it is sometimes quite difficult to actually differentiate a primary, whether it's a forefoot driven cavus or a hindfoot driven cavus. And that's the question really in a cavus foot that we are talking about, the heel varus. So if there is a primary problem in the hindfoot, just like a subtalar osteoarthritis or a previous calcaneal fracture or something else which is going on primarily in the, like peroneal weakness sometimes causes primary hindfoot varus. And so if there's a primary problem in the hindfoot, then it is hindfoot driven cavus. And if it's a forefoot, so if it can only be differentiated in the earlier stage. Okay. So usually if you allow the first metatarsal to drop, if the hindfoot varus corrects, then it is a forefoot driven cavus. So it's the primary problem is the forefoot. As soon as you're correcting the forefoot, the varus is correcting. However, in the Coleman block, if the forefoot drop test, the hindfoot varus does not correct. That means it either two things. It's either primary hindfoot varus, primary problem in the hindfoot, or the hindfoot subtalar joint is already fixed in varus. So either of those two. And then to differentiate between these two, then you can do a passive movements of the joint to see whether it's a fixed varus or a flexible varus. If it's a flexible, then you can say that it's a primary hindfoot varus. Did you get that, or was that a bit?
Yeah.
Make it a bit clear or not, and made you more confused?
Oh, that's an excellent.
Yeah, we got that.
Professor Chinmay, sir, you want to add anything else?
It is primary by the different tests like Coleman block test or other test. It will not be corrected because it is rigid. But if it is secondary to other deformity, like high forefoot deformity, usually it is flexible and it will correct. So it is usually secondary. The important test is Coleman blot. That is the most important test.
All right.
Okay, sir. Right.
So another question, what are the clinical signs of vertical talus?
Congenital vertical talus, na?
Yeah, congenital vertical. Yes. Chinmay sir, please.
Rocker bottom foot. The
Yes.
best one is the rocker bottom foot. That is the commonest one. The clinical sign is the rocker bottom foot. And here the entire management is dependent on a lateral view X-rays. So that is very important. But clinically, rocker bottom foot is classical of a congenital vertical talus.
Chinmay
So
sir,
one
would you like
question
to
is
add
there.
anything?
Rocker bottom flat foot actually rigid flat foot. In flexible flat foot, you can correct the deformity by flexing after extending the great toe and also by passive movement. But if it is vertical, due to vertical talus rigid, you cannot correct it passively. Number one. Number two, you can feel because there is break in the talonavicular joint, you can feel the head of the talus at the sole. And number three, the foot is placed in equinus. It is basically equinus deformity, equinus and rigid flat. So these are the three signs you can diagnose vertical talus.
Sir, another question is, when the flat foot will become symptomatic? Professor Chinmay, sir.
Nicely described by Maninder Singh. Unless there is some other pathology, it is usually asymptomatic. Most of the cases are asymptomatic. But if due to some disease or aging process or weakness of the muscle after prolonged illness, the arch further collapses during weight bearing, then degeneration starts and it usually becomes symptomatic.
Yeah, I would agree with that. And can I add to that as well that sometimes in severe flexible flat feet, the early teenagers can get quite symptomatic with that, and the treatment for that is usually conservative with arch supports and exercises for strengthening the tibialis posterior. However, if sometimes the symptoms don't improve with conservative management, and then they can be helped with calcaneal osteotomies and corrective osteotomies to realign the flat foot. And that usually helps. There is a lot of procedures which have been described now and which are quite successful.
Which is not related.
Yeah.
Yes,
please go ahead, sir.
Moderate to severe flat foot and without an accessory navicular, older child, and there are symptoms of foot strain on standing, and there is no excessive wearing out of shoes. So usually insoles are enough. But if you have a very severe stiff flat foot in an older child, and there is appearance is also not acceptable, so then we can, as Dr. Maninder told, medial displacement osteotomy of the calcaneum. And sometimes when it is very painful and severe flat foot in an older child, we can exclude a tarsal. We have to rule out a tarsal coalition. That is again very important. And then we have to plan for a subtalar fusion in these cases in a flat foot.
Yes, MAINAK, you were asking some questions.
That is the insert will be sufficient, and when you have to go for osteotomy. But Samarjit already answered the question in advance.
So can I add to that?
Another question, Dr. Maninder?
Yeah, Maninder, please.
So there are different osteotomies to correct the flat foot deformity in children. There is two osteotomies in the calcaneum which are possible. The medial displacement calcaneal osteotomy, as Dr. Samarjit said, and there's also lateral lengthening. It depends on when you do a standing X-ray of the foot in the AP view, how much uncoverage of the talus head is there, how much of the navicular is actually moved laterally. And if there is significant uncoverage of the talar head, then a lateral lengthening osteotomy of the calcaneus is very successful operation This can be usually combined with the medial cuneiform osteotomy, usually a dorsal opening wedge or a plantar closing wedge osteotomy, to actually supinate the foot and bring down the first metatarsal, so to make the foot plantigrade. So this is required even in fully flexible flat foot, which are usually moderate to severe, as Dr. Samarjit said. But these are for symptomatic patients who failed a reasonable trial of at least a few months of conservative management and physiotherapy, and they're not improving. Then we can offer them these osteotomies.
So one question is to Dr. Maninder. Hello, can you hear me?
Yes.
When will you operate in a case of tarsal coalition syndrome?
When do we operate?
What are the indications?
Indication is mainly pain. So there's a lot of tarsal coalition which are asymptomatic. And you'll find that some people in their 30s or 40s come to have pain in the subtalar joint, and sometimes they found to have tarsal coalition. And depends on the type of tarsal coalition there is. Usually a fibrous coalition will cause less symptoms. Bony coalition will cause symptoms early. The symptoms, majority of the symptoms are caused in the teenage years. Okay, about 13, 14, 15 is when they start getting symptoms. At that time, the cartilage of the subtalar joint is still okay. So if you are able to, operate on these coalitions, subtalar, especially I'm talking about talocalcaneal coalition, if you're able to operate before 15 years of age, then we are usually able to salvage the joint, and we can just release the coalition and put a fat layer in between the two joints so that there's no further coalition, recurrent coalition possible. But if it's 4-15, usually subtalar joint is already degenerated, and then what is required is a subtalar fusion. So you need an MRI to look at the cartilage that is there to see for any degenerative changes that already occurred in the subtalar joint or not.
Cartilage of the subtalar joint.
Yes, that's right.
So what is the ideal timing for operation?
So it's usually before 15 years of age is when the cartilage seems to be normal. After that, if you find a coalition, they're usually but even if you have an 18-year-old with a cartilage normal, that basically will happen in a fibrous coalition. Then you can just release the coalition, and the patient will get good relief. You can excise the coalition.
Before 15, the valgus deformity can be corrected?
No. Usually the valgus deformity is there, but it doesn't become symptomatic before 12, 13 years of age. It doesn't become symptomatic before that, normally.
Yeah. Symptomatic means severe pain, no?
No. Some people, before 10, 12, usually coalition is completely asymptomatic in children. Even though they may have a fixed valgus deformity of the foot, it doesn't cause them pain. And even with the, talocalcaneal coalition, as I said, majority are still asymptomatic even in adult life. So it doesn't necessarily mean that if you have coalition, we'll need to have surgery.
Okay.
There is one question, Maninder. There is any clinical test for motor neuroma?
Yeah, so I demonstrated the Mulder's click, in which you press the whole of the forefoot. If you have the recording, then you can, I think YouTube will be able to see it. But you can do the Mulder's click. That's the most common test that is there. And then the other diagnostic test is an injection into that area. That's the only two, diagnostic tests that are there for motor neuroma. But both of the tests are not really very specific or sensitive. So it's more of a clinical diagnosis, and you can do an ultrasound or an MRI, a dynamic ultrasound or an MRI to confirm the diagnosis. Majority of times with the clinical diagnosis of motor neuroma, the radiological diagnosis cannot pick it up still. And sometimes you may have to intervene, just on a hunch rather than radiological confirmation.
And how will you clinically diagnose the chronic syndesmotic injury?
Yes, I think that's a really good, important question. So a chronic syndesmotic injury will have pain in the syndesmotic area, which is just above the ankle joint on the anterolateral aspect. If you have high ankle pain, basically it's called as high ankle pain. If you have pain in that area, and if you have signs and, the way to stress the syndesmosis clinically is an external rotation stress test. So you external rotate the ankle, and if you have pain in the syndesmosis, then that's a sign of a syndesmotic problem. The other test is a calf squeeze test. where you press the proximal tibia and fibula together. And if you get pain in the area of the syndesmosis when you're doing that, then it's basically another sign of a syndesmotic problem. Always confirm with either a CT or an MRI the degeneration around the syndesmotic, or if there's any subluxation of the syndesmotic joint.
Okay, thank you.
So there is one question for please, Samarjit.
Regarding the tarsal coalescence, I think there is a role for a plaster immobilization, a trial of cast immobilization for 3 to 4 weeks. And that actually differentiates us from whether they really require for any resections or any sort of arthrodesis procedure or osteotomies, and from the ones which can be managed with orthosis and shoe modifications. I think that's again an important
I think definitely agree with that. That conservative trial of before excision of any coalition, a conservative trial will always help. Definitely will be tried. Should be tried before we go ahead and do things.
So cast immobilization in what position?
I think that's the functional position of the foot only. There should not be any
normal,
particular
neutral. Yeah.
It's a plantigrade foot.
Yeah.
Plantigrade.
Plantigrade functional position. Yeah.
Below knee.
Below knee. Yeah.
Samarjit, there is one question. So how do you define rigid foot, rigid club foot?
Rigid club foot. Okay. I think let Sir answer this. No?
Chinmay, sir.
Chinmay,
so rigid club foot.
Club foot, actually there are a few signs. What is very, for the rigid club foot, the heel is very small. Heel is very small. And if you palpate the tendon-Achilles, it will feel like a steel wire. And if you look at the medial side, it is actually, nowadays it is assessed by the Pirelli score, but these are the 3-4 signs: small heel, very rigid, stringy tendon-Achilles, and on the medial side of the foot, you will have too many creases, and passive correction is almost impossible. So this is to start with. This is the few signs, and on the lateral aspect, you could try to pinch the skin. Lateral aspect of the foot, try to pinch the skin. It is not possible. It is stretched. So these are 4 signs: heel, small heel, stringy tendon-Achilles, too many creases on the medial side, and tight skin on the lateral skin of the foot.
Thank you, sir. Yeah, MAINAK, any more questions there?
No, I do not have any further question. You screening ARNAB video is coming, okay?
No. The streaming stopped, but we are recording, so we'll upload later on.
Yeah, I think something is there.
Okay.
YouTube
Uploaded.
that there was something copyrighted. They detected. That's why they have stopped the stream.
Oh, achha.
This problem
YouTube is very sensitive.
Yeah, you can't do it. Just one question I like to ask all the panelists, that sometimes a chronic foot drop is given as a short case to PGTs. So we know that the cause is anywhere else, not in the foot basically. But what are the things to look in the foot in a chronic foot drop case? What are the things we should PGT should examine? That if anybody can answer.
Yeah, Maninder, you can take this question.
Okay, so chronic foot drop, I think there's 2 or 3 things which obviously we need to see. One is the muscle power, which has caused how much muscle power is actually left in, if there's any muscle left to transfer. So because we're planning treatment, we need to know the muscle power all around the foot and the ankle. So we have to test all the anterior and lateral and posterior compartment muscles for their power, and see if the foot is balanced or not in terms of the muscle power. If there's more of lateral power, then we may need to transfer that to the dorsum too. So we have to basically look at the muscle balance, overall muscle balance of the foot, and whether the tibialis posterior muscle is there for us to transfer to the dorsum, or whether we can do a split Achilles transfer to the dorsum, so that we actually plan treatment. The other thing to is in a chronic thing is whether we have any degeneration in the foot already happened, or whether there's any fixed varus or valgus deformity already there in the foot, which will impact our treatment. So you have to look for any fixed deformities in the subtalar and the foot. The ankle in a foot drop usually is usually flexible enough. But it's more the midfoot and the hindfoot which can develop deformities over time. So I think that's an important thing to note at that time to plan treatment. So basically, these are the two main things.
Okay. Thank you. So I think there are no more questions. Shobhita, do you have any? Sir,
I think all the
Roy,
questions.
yes.
Devashish sir, yes.
No further questions from me.
Yes, sir. Sir, please unmute yourself. Yes, sir.
I
Yes,
will
sir.
manage a neglected talofibular ligament tear in an athlete.
Sorry, sir, I didn't get that question.
Neglected ATFL.
Yeah. So that's the most common injury in the ankle is a ATFL tear, and majority of them are neglected because we keep walking on them, and we ignore our injuries. And majority of patients do that because their foot is relatively stable, and they're able to walk on it, and that's the correct treatment actually. Is to neglect it till it causes problems. So what are the problems? Is one of the most common problems in a ATFL tear is there can be two types of problems. One is an impingement problem where there's a formation of scar tissue intra-articular, which will cause pain on the anterolateral aspect of the ankle, especially during dorsiflexion. So if you dorsiflex the ankle, you will have pain on the anterolateral gutter, and that's the most common symptom which people are left with. The other common problem is an instability. So if you have instability and impingement, then you have to treat that accordingly. Usually, patients are given a trial of at least a few months of conservative management, which includes proprioception, balance, strength training exercises. And I usually advise the patients about 2 hours of exercise a day. And if they're able to follow it for 2-3 months and they're still symptomatic at the end of that time, then I would offer them surgery. Is basically to reconstruct. Usually I do it arthroscopic reconstruction of the lateral ligament. Along with impingement, we take out the impingement lesion that is there and we reconstruct the lateral ligaments at the same time. It depends on the hyperlaxity of the patient. So some people are very hyperlax, and then we tend to do an open surgery to put an internal brace reconstruct as well. But that's less required. Majority times, modified rostrums repair using arthroscopic or open techniques is good enough.
Thank you.
Yeah. I think all the question has been answered, and thank you, Maninder. Thank you, Samarjit da. Thank you, Devashish sir, Chinmay sir, and thanks to ARNAB. There is some issue is YouTube streaming. I think we have recorded this and we will upload it today only. So, Chinmay sir, please summarize of today PG crash course foot and ankle module.
Today, the examination of foot ankle is nicely described. This part of the examination open little thought to the students. Even we as faculty little know about the examination of the foot and ankle. So myself also, I learned many things of the faculties. So a few things to be clarified. One is plantaris, power of plantaris. Plantaris actually is a struck muscle, a river-like muscle. So test its power is not possible, but its continuity can be tested by squeezing the passive squeezing the calf if some movement of the ankle plantar flexion, usually plantar is intact, otherwise it is divided. And regarding the movements of the ankle joint, as in other joints, basically there are two types of movement. One is active movement. This is in the ankle joint, dorsiflexion or plantar flexion, and active primary movement. And accessory movement is the rotation, which is combined with the, as described by Dr. Maninder, it is combined with the dorsiflexion, plantar flexion. There is introduction and extrusion. And another movement is there, which is basically a passive movement, what the surgeon or examiner can elicit and what is there when accident occurs. That is why we often have abduction injury and adduction injury. And how to test the heel varus or valgus? Basically, it is tested in standing position. It is allowed to stand and look from back. Draw a line along the axis of the tendinalis and draw another line at the middle of the calcaneum. So usually there should be straight line. If it deviates outwards, it is valgus, and if it deviates, the calcaneal line deviates outwards, it is the valgus. If it is deviates inwards, it is varus. Up to 3 degrees is acceptable as normal. If it is more than that, it is pathological, may not be symptomatic. And too many toe signs as it is applied also for assessment of the adduction of the forefoot. If you look from back, if other than great toe, other toes are visible, there is adduction of the forefoot. So if you describe, I think nothing is there to be known about the foot and ankle examination problem, congenital and hereditary age group and adult age group. So everything has been explained, and thank you, the faculties from Delhi and Bhubaneswar. Thank you all.
Thank you, sir.
Thanks from Partho. Our secretary has joined, I think, because of some internet problem was there. Partho?
Partho, please unmute yourself.
Unmute yourself, Partho.
Partho?
Yeah, thank you all for making this PG Crash Course Module 8 Foot and Ankle so interactive. And thanks to our faculty, especially Dr. Maninder Singh and Dr. SAMARJIT PATNAIK. And thank you, sir, Dr. Devashish Sinarai, sir, for inspiring us and for your active involvement. And thank you all. We will have some next PG Crash Course program also. Thank you.
Thank you all.
Thank you for the kind invitation. I'll come back anytime you want, please.
Yeah. Thank you. Thank you, Maninder.
Thank you.
Thank you,
Right.
Rajeev.
Good night, everybody.
Singh,
Good night.
thank you for coming. Thank you, sir. Good night, sir.
Good night.
Stay safe, stay well.